So I have no conflict of interest to declare. So this journey of sleep apnea, I've seen it, it's about discovery of sleep apnea. It's about how we understand sleep apnea and its complications. And it's about how we use different approaches that we have learned by treating patients, medical and surgical approaches to the upper airway to treat this patient. It is also about innovation, resilience, and creativity by sleep surgeons to treat this group of patients. And ultimately, of course, it's about the whole sleep community coming together to improve patients' outcome. When I talk about holistic management of sleep apnea, there's three things that I'd like to touch on today. First, of course, is integrated multidisciplinary treatment. And I hope that, at the end of this talk, you go beyond that, think about the associated medical conditions, think about screening, think about preventing. Okay. So when we talk about adult sleep apnea, we're quite comfortable with multidisciplinary treatment, and we have gone through this, I think, many times over this 1 or 2 days. But we also talk about, whether or not it's important for us to treat patients, that are at risk of developing medical conditions because of sleep apnea. And some of these things, it's associated medical conditions, affecting the heart, affecting the brain, affecting the eye, neurology. Yesterday we talked about the heart conditions, the stroke and all these things. Some of these things we have to bring out the awareness to our community. And also we've covered the PEDS sleep apnea, and of course the multidisciplinary treatment. But what we have always done is to separate the pediatric and the adult into two different groups. But all adult sleep apnea, I suppose, I would say all, but a lot of them comes from the pediatrics. So if we can arrest that progression, that I think will be something that we can and should do. And of course, identifying the child at risk for sleep apnea and treating them to prevent the development of PEDS sleep apnea and its progression. And yesterday, I think we talked about awareness. I think it's important for us to communicate with our family physicians, not just ENT alone, but family physicians, to bring this awareness out to the community, in line with, I suppose, the vision of this conference. So when I look at sleep apnea, it's actually the first wave would be us discovering and understanding sleep apnea, going through the treatment strategy, and third wave translating the care and precision medicine to bring specific, I suppose, precision care to our patients. So since Christian Colomino described sleep apnea way back in 1972, we have a better understanding of it now. We know that there's repetitive upper airway obstruction, there's oxygen desaturation, there's arousals, there's sleep fragmentation, and all this leads to all this complication that during the fireside chat we talked about yesterday, uncontrolled hypertension, ischemic heart disease, pulmonary hypertension, road traffic accident, there's a metabolic syndrome and stroke. And we know that it is associated with mortality if untreated. And that's the reason why I suppose we are here, because we want to prevent and we want to treat all these complications from happening. And it is not, I guess, easy for a surgeon to say that he can actually treat something that affects the entire body. And as an ENT surgeon, as an ENT surgeon that specializes in sleep, this is something that we can do. So look at the literature, there's 1 billion patients, supposedly affected by sleep apnea worldwide. In Singapore, about 30% of our middle-aged male has got sleep apnea. And yesterday, as we were talking about data, actually in India itself, there are some data out there to show that, it affects 3.5 to 13.7% of the population, depending on how you look at it. And of course, for OSA syndrome, it's from 1.7 to 3.5 or 3.6%. And if we extrapolate it, to the world, or to the Indian population, in the world, India is the second most populous country in the world. Just 1%, 3%, or even 10% of 1.3 billion, you can imagine how many patients are going to be affected by sleep apnea. and of course the medical consequences and the cost of it. And other countries have done those costs in terms of dollars and cents to the economy and to the country. It goes into billions. So much so that at some point in time, World Health Organization declared sleep apnea a public health crisis that we have to do something about. So the number of people that we need to do this is a lot. I don't think it's going to be enough for the people in this room or this hall to look after. That's why the association has been going around to different states, different countries, or rather different states in India, propagating the knowledge, propagating some of these needs that needs to be done. Second thing, we talk about multidisciplinary treatment. As you can see, you name it, any form of treatment, you can find it for sleep apnea, be it medical treatment, surgical treatment, devices treatment, or lifestyle management. So at some point in time, you might be wondering, how am I going to integrate all this into your practice? How am I going to benefit for patient? So my approach to this is that, what is the best treatment for the patient? We talk about single treatment of the nose, of the palate. We talk about surgical treatment. We talk about device surgery treatment. But at some point in time, I suppose we can always use multi-modality treatment. And I hope that you all will go away knowing that it's not you don't have to use one treatment, but you can use multi-modality treatment. And on the left-hand side, you can see that what I tell the patient most of the time is that they need to, of course, look at their sleep hygiene, weight management, myofunctional therapy, persuasion therapy, and of course, assess the skeletal, the tone, and look into the patient's expectation, occupation, age, and comorbidities. Well, we always say that the main treatment is CPAP treatment, and that a lot of patients fail. That's why surgical treatment is being propagated by Stanford way back in 1984. But instead of talking about one treatment versus the other, or one treatment over the other, now we're talking about combined treatment. We're talking about how we can use surgery and CPAP together to impact our patient. Like for example, a patient with nasal obstruction, with sleep apnea, if they're not able to use a CPAP, we can use surgery first before treating the patient's sleep apnea. The patient is not tolerable to CPAP because for whatever reason, doesn't mean that they will not be able to use a CPAP for life. Sometimes we use surgery either to initiate CPAP to bring down the pressure so that they are more compliant, or even in patients who are initially not tolerable to CPAP, we can actually use that to start CPAP treatment. And it's been clearly shown in this paper that some of the patients was intolerable to CPAP, but using palatal surgery, nasal surgery, thoracic surgery, the patient was able to use CPAP. And we can combine it even with mandibular advancement device. And we know that MMA is the most aggressive and most effective surgery, but over time it can fail. The patient can have relapse. Doesn't mean that it's the end. Currently now we have hypoglossal nerve stimulation that can tackle the tone in this group of patients. So while we like to use a guide to say that, okay, if I have this, I do that, if I have that, I see this, I do that. But ultimately, I think what we want to do is what is best for the patient, and we have to gain all the knowledge as well as all the armamentarium and all the right tools to treat this group of patients. When we talk about sleep apnea, single modality treatment, if it's possible for us to use one single modality to treat the patient, and the patient can use that single modality or that treatment for life and continue without CPAP, I think that would be the best. But a lot of times we know that that might not be possible. We can do what we want to do to the patient. It may just improve a little bit, but that doesn't mean that we don't have other things in our sleeve. We can add on CPAP with surgery with medication, with myofunctional therapy, so on and so forth, to treat sleep apnea. So in time to come, I think we are going to go more and more into precision medicine for sleep apnea in the sense that we're able to know exactly, given the patient's demographic, morphology, the endotype or the phenotype, treat the patients. But what always comes to my mind when I treat the patient is that does all the patient require treatment? So if a patient with sleep apnea, AHI is mild, rather mild, moderate, severe, but they're not affected by it, they're really relatively asymptomatic. The spouse is not bothered by the snoring. Do we need to treat the patient? Because I've seen the a patient 80 years old, with severe sleep apnea, and still say that, well, I have this probably for the last 10, 20 years. I'm still 80 years old. I'm already 80 years old. Why do you want to do so many things to me, right? So I'm sure you have come across different patients. So that's all the patient require treatment. Is it possible that some patients are just naturally, genetically advantaged such that they do not suffer the consequence of sleep apnea? I don't have the answer. I'm just asking the question, but I think those are possibilities. And of course, we talk about different soft tissue skeletal surgery and when to do all these things and when to add devices to all this treatment. And of course, I think it will count patients' preference. But going back, to this screening and prevention, we talk about treatment of sleep apnea, and you have heard multiple times about how we're trying to change the skeletal structure of a patient. This Dr. Audrey Woon's talk on this skeletal expansion. Essentially, what we're trying to do is not just to treat sleep apnea, but I think possibly preventing some of this sleep apnea from being cemented. So what if we can turn back time, such that we can prevent sleep apnea from happening? Wouldn't it be great? So I believe that most patients, unless of course they are syndromic or they are have congenital abnormalities, born without sleep apnea, except for those with Malaysia that is not that good with them. But I believe that a lot of them probably are not born with sleep apnea, but maybe they are predisposed, either genetically smaller airway, but over time, because of environmental factor, allergy, sleep deprivation, weight management, weight, and then because of eating, drinking, and talking, trauma to the airway, probably adding on smoking, alcohol, or unhealthy lifestyle behavior, lead to them having sleep apnea, and of course, its medical consequences. So, if we are able to prevent or identify some of this from young, it will be, I suppose, great in the sense that we can possibly, delay, I suppose, sleep apnea from happening early, or rather delay its onset, such that the patient has less time, to develop some of these complications. We've talked a lot about this, in terms of the skeletal malocclusion and how it is to sleep apnea because of maxillary and mandibular growth. So one of the things that I think we have to remember as ENT surgeon is that sleep disorder breathing do have an impact on the facial growth, in the sense that if they do not breathe in through their mouth, or like they don't breathe through their nose when they sleep, the tongue is not going to abut the maxilla, it's not going to push it naturally, and hence you can lead to a lower tongue position, extended head posture, lower mandibular posture, leading to what we call the adenoid facies, but sleep apnea formation. So this has been quite well shown in this primate study. So Dr. Jules Halvoy did this study where he artificially plucked out the nose of primates, baby monkeys, and essentially these monkeys developed a malocclusion and a smaller jaw. And he showed that once you remove that nasal obstruction, it does get better. And I think in clinical studies, I think there are some studies to show that that can happen. So what if we can prevent some of this? I'm sure you have seen a lot of patients with this malocclusion, small jaw with this pointed teeth. So oral breathing definitely leads to underdevelopment of facial skeletal structures and the smaller upper airway, as shown by some of this systematic review and meta-analysis. But if let's say for example you can identify them, we surgically treat nasal obstruction, is it too late? Okay. So when we look at some of the data out there, what is still a bit equivocal in the sense that some studies show that it does help in increasing the maxillary arch width and decreasing the lateral crossbite frequency. But some show that it may not actually help in horizontal mental roof, which is what we want. And if we know that sleep apnea prevalence is about 1 in 10 in just patients, and almost all pediatric OSA patients snore. So is it possible that if we screen some of these patients from young, we can identify them, stop all these things from happening? Well, I think it's possible. The American Academy of Pediatricians has already sort of issued guidelines to say that in pediatric patients going for routine health maintenance, these patients should be screened for sleep apnea, meaning that these are not patients that comes to the pediatrician or the ENT with related conditions, but they actively ask the patient, or rather the parents, does the patient snore, and do they have any of these symptoms that are suggestive of a childhood sleep apnea? So screening actually starts from there. And why treatment? Why do we want to treat early? Of course, there are studies to show that it does help with academic function, and of course in the general quality of life. Okay, so India, Singapore, quite a competitive society. Definitely, we want our child to do the best, and sleep and treating the sleep apnea is one of the way that I suppose we can achieve that. Okay, but that doesn't mean that if we remove their tonsils and adenoids, I know that we do a lot of those in kids, but that doesn't mean that we treat their problems once and for all. Just remember that even after that treatment, 80% may have still residual sleep disorder breathing, and they may require other treatment. Which means that once you diagnose them, perhaps those processes that can lead on to sleep apnea has been already formed, and that they require other intervention to make sure that we resolve this. Again, just to reiterate that doesn't mean that we treat the tonsil adenoid, they will not develop sleep apnea. If they still have nasal obstruction and still mouth breathe, because the habit is formed, they will still develop sleep apnea. Going on a little bit to screening in adults, there guidelines to tell us that we should actively screen patients for sleep apnea in adults. Well, the evidence is still equivocal, and I suppose for a symptomatic patient, the US actually doesn't recommend that. I know that yesterday we talked a little bit, a lot about screening, but currently there's still no evidence to say that we should go out to the community and start saying sleep apnea is something that rather do a sleep study for patients without symptoms of sleep apnea. Of course, other than their professional airplane pilots and truck drivers. Okay. So now, we talk about multidisciplinary treatment, prevention, and screening. So the reason why we treat sleep apnea is that we want to prevent some of these cardiovascular complications from happening. But if you look at some of the studies out there, it does not actually show a positive effect when patients are treated with CPAP. I know that we only have CPAP data because that's the standard treatment that people keep talking about CPAP data. But even in patients that are treated with CPAP, somehow we are not able to achieve what we want. Meaning that yes, maybe it stops snoring, maybe their quality of life is better, but all these trials have not shown that they actually reduce cardiovascular comorbidities. Perhaps treatment of sleep apnea does not prevent cardiovascular event, or is it because we're not looking at the correct indices? Or maybe by the time they have been diagnosed with sleep apnea, especially severe, and they want to treat it, some of the processes has already been set and it's too late, or because some of the data showed the insufficient use of CPAP. If you look at the SAFE trial, they reported that the patient used just about 3.54 hours of CPAP. So that may not be possible, or whether enough to treat patients with sleep apnea in terms of reducing their cardiovascular complications. Perhaps primary prevention is the way to go, in the sense that really go upstream rather than downstream. And now that we have another treatment called hypoglossal nerve stimulation that can really treat the patient, perhaps with some of this data coming out, that will give us more data to see that, to show that we are doing good work. So again, one of the things that I've always been wondering is whether primary prevention is the way to go, because by the time you diagnose a patient with sleep apnea, a lot of them already have a subclinical coronary artery disease. So in this study that we published as an abstract to the American Cardiology Society, at least 1 in 3 would already have some form of subclinical coronary artery disease. And the age and the severity of the HI actually created coronary artery calcium score, which is what we use to sort of as a surrogate for coronary artery disease. So which means that, the more severe the sleep apnea, they have a higher coronary artery calcium score. So is it possible that by the time that is established, it's a bit too late? In a sense, that's why some of the studies doesn't show that treating the sleep apnea actually prevent the cardiovascular comorbidities. Well, I hope that in the future we'll have more studies to look at primary prevention and how this really prevent this sleep apnea. Okay. And we talk about this associated medical conditions. We know some of this already. We know ischemic heart disease. We know hypertension. Yesterday we have a cardiologist talking about it. We know about stroke. Again, I think we know about this road traffic accident and how it can be a big issue. But there are actually other associated medical conditions that are out there. So I'm quite ashamed that even though I specialize in sleep apnea, it was the eye doctor who pointed out to me this. They referred the patient to me and say, "Dear Dr. To, this patient has normal tension glaucoma. Please have a look to make sure that the patient has sleep apnea." So I was very puzzled. Saying, "Hey, is there really an association?" And that happened about 6-7 years back. So thereafter, I know that we did some studies together, and we showed that at least if you have moderate to severe sleep apnea, you have a higher chance of developing a normal tension glaucoma compared to the normal individual. And we know that glaucoma is one of the most important cause of blindness in adults. So, and we subsequently did some systematic review and meta-analysis to show that, if you have sleep apnea, definitely you have a higher risk of glaucoma. And not just that, the floppy eyelid syndrome as well. So now we work quite closely with our eye surgeons as well. They actively refer patients to us and to screen for sleep apnea, and vice versa. Sometimes we do refer patients, especially those with severe sleep apnea with vision problem, to them to screen for glaucoma. Okay. And the other thing is cancer. I know cancer is the second leading cause of death after cardiovascular issues in the world. So there is concomitant, I suppose, pathomechanism that between cancer and sleep apnea in terms of immune dysregulation, hypoxic drive, sympathetic activation, and some of this factor has been shown to affect carcinogenesis and this metastasis. So my team and I, we did some meta-analysis again to look at what are the factors that can drive some of this. We found that nocturnal hypoxemia is independently associated with more cancer risk and mortality. just OSA diagnosis alone doesn't, but if the patient have got a high hypoxic burden, severe sleep apnea is definitely associated with it. So that means that if a patient, cancer patient, has sleep apnea and is not treated, they may be looking at higher mortality comorbidities associated with it compared to one who don't have sleep apnea. And we have found that for breast cancer, lung cancer, as well as a few other cancers. So I suppose in conclusion, I just want to highlight to you all is that, well, when we talk about multidisciplinary or integrated treatment, we should be thinking beyond that. I think at every point in time, we should be thinking about whether or not it's possible for us to find a way to screen, prevent some of these comorbidities from happening, because those are a huge burden to our society. And those comorbidities that I've mentioned and we discussed yesterday, I think it presents a great opportunity for us to impact more patients, because I think that's the reason why we are here. We are here because we want to improve the lives of our patients. So with that, I'd like to give a special thank to Srinivas and his team, for bringing together and organizing such a huge and successful conference, and for your hospitality. With that, thank you.
Thank you, Dr. Song.